everyone. Welcome back to another episode of Psychiatry Rewritten. My name is Lane. What if borderline personality disorder isn't really a disorder at all? What if it's just chronic trauma that's been medicalized, renamed, and turned into a diagnosis? Think about it. It's easier for the system to call it a disorder than to sit with the reality that people are carrying around unbearable trauma stemming back generations. Borderline becomes a way to medicalize pain instead of honoring or recognizing it. A way to turn unhealthy coping skills into diagnostic symptoms. To minimize trauma down into a label and blame the individual who has been diagnosed for the scars. Now let's be clear. None of this is about excusing blatant poor behavior. Borderline personality disorder can involve destructive, painful patterns, and those patterns hurt not only the person living with them, but also the people around them. We're not pretending those behaviors don't exist, and we're not excusing them away. But maybe the truth, and most importantly, maybe the healing, lives somewhere in between personality traits and chronic trauma. Maybe what looks like dysfunction is actually adaptation. And maybe giving people the space just to be themselves without conditions could be healing in itself. Let's start to break this down. What does borderline personality disorder actually look like? Also known as BPD, you will hear me refer to the disorder as BPD throughout the episode if you're not already familiar with that. So what does BPD actually look like? It looks like fear of abandonment, emotional dysregulation, self-harm, self-destruction, intense relationships, dissociation, empty identity or sense of self. Now, in comparison, what does trauma look like? It looks like hypervigilance, fear of rejection, emotional flooding, self-destructive coping, dissociation, a fragmented sense of self. The overlap is uncanny and undeniable. That individual with caregivers who just left unpredictably. That individual may hyper watch people. Even into adulthood, they hyper watch people for signs of abandonment or rejection. With emotional flooding, maybe a survivor learns early that feelings are terrifying, learns early that intense emotions are terrifying. Now, a minor criticism triggers a wave so intense it's overwhelming. It's not emotional volatility, it's a brain that's wired to function and behave in a certain way. Or self-harm as regulation. Cutting isn't a cry for attention, it's a distraction from intolerable inner pain that an individual is experiencing. A trauma survivor turning emotional overwhelm, emotional chaos into something they can actually control or touch. And then dissociation and identity fracture. Some trauma survivors describe feeling like a ghost in their own life. Days slip by unregistered. That blankness mirrors BPD's identity fragmentation and is a deeply human failure to survive overwhelming experience. But nonetheless, research shows childhood abuse and neglect strongly correlate with developing BPD later on in life. 50 to 80% of people with BPD engage in self-harm of some kind. Up to 10% do die by suicide. Individuals with BPD have higher suicide mortality rates, 5.9%, than those with other personality disorders, which is more like 1.5%. Structural and functional imaging consistently finds differences in brain regions like the amygdala, orbitofrontal cortex, hippocampus, and anterior cingulate, which are all areas that are tied to emotion regulation and trauma processing. Recent reviews identified dissociation, which is the disconnection from self and feeling. Some people describe it as being out of their own body or like feeling like a third person. And recent reviews identify this as a shared hallmark of both trauma and BPD with clear neural correlates. So there's clear correlation and evidence of correlation in the human brain. And PTSD, complex PTSD, CPTSD, and borderline personality disorder feature overlapping symptoms, suggesting they could lie along a continuum, like autism is a spectrum, rather than be fully distinct. When you line it all up, the symptoms overlap. The trauma trajectories, the suicide statistics, and the brain signatures, the question starts to feel less radical and more obvious. Is borderline personality disorder truly a personality disorder? Or is it trauma? Just a vibration of survival wounds echoing through, manifesting through behavior, thinking, and identity. If BPD looks so much like trauma, then why did psychiatry split them apart in the first place? Well, the answer isn't very flattering because it's just about history, politics, and bias. PTSD was built for soldiers, not survivors of abuse or neglect at home. When PTSD first entered the DSM in 1980, it was created to recognize combat trauma in the soldiers who were in Vietnam, that were returning from Vietnam. So PTSD was first entered into the DSM for the Vietnam War veterans. That was the respectable kind of trauma. The kind psychiatry was finally willing to take seriously. But what about survivors of childhood abuse, neglect, abandonment, sexual assault? Their pain was harder to categorize. So instead of calling it trauma, psychiatry invented borderline. Let's not ignore the gender bias that exists. From the start, borderline was used disproportionately on women. Women who were angry, women who were suicidal, women who were emotionally reactive, women who didn't fit the mold of the quiet, compliant. PTSD went to men who'd seen war. Borderline went to women who'd survived war in their own homes. There's also a psychological comfort for clinicians in separating them. If we call someone traumatized, it keeps the focus on what happened to them. If we call them borderline, the focus shifts onto the person, their traits, their flaws, their instability. One makes us look at the world and how it harmed them. The other makes us look at the patient and say, "You're the problem." That's a lot easier for a system that doesn't want to deal with messy realities like abuse, and neglect. Here's the kicker. Even the treatments reflect this divide. PTSD patients are approached with compassion, right? Trauma therapy, EMDR, a narrative of survival. Borderline patients are approached with suspicion, DBT, and a narrative of manipulation. But look closely at DBT. Mindfulness, distress tolerance, emotional regulation, safety. It's trauma therapy wearing another name tag, which raises the question, if we were honest about what borderline really is, would we still treat these groups differently? Would the divide still exist to this extent? So borderline and trauma weren't split apart because they're actually so different. They were split apart because psychiatry had room for one story at that time. Instead of expanding the trauma category, the field created a new label that carried all the stigma and none of the honor. There are a lot of misconceptions about these two topics. One misconception is borderline personality disorder and trauma are totally different. They're not. Neuroscience says otherwise. Brain scans of people with BPD and people with trauma show the same hotspots. The same areas of their brains are active during these situations. Hippocampus that's been worn down by chronic stress, and a prefrontal cortex struggling to regulate the storm. Symptom networks are almost identical too. Fear of abandonment, emotional flooding, dissociation, different names, same nervous system. If psychiatry hadn't siloed them, we might have called borderline what it really is. Complex trauma that's just been deeply ingrained and written into the brain and body. Another misconception is that borderline was a neutral scientific diagnosis, right? That's not true. The history is messy and gendered, like we talked about. PTSD went to the soldiers when they got home, and borderline went to the daughters. Same nervous system, same type of scars, just different names, different labels. But one of the biggest issues is the fact that the split between BPD and trauma isn't just academic. It shows up in how people are treated on a daily basis. And the difference couldn't be starker. When someone is diagnosed with PTSD, the response is almost always compassion. It sounds like you went through something horrible. You survived it. Your brain is doing the best it can under the circumstances it was given. The treatment plan? Trauma therapy, EMDR, somatic work, meds to stabilize flashbacks, nightmares. The message is, this is a wound, and with the right care, you can heal. Now, compare that with borderline. The tone shifts immediately. The words change. Instead of survivor, the label becomes manipulative. Instead of compassion, it turns to suspicion. The treatment plan? A watered down mix of crisis management, safety contracts, and maybe a little DBT if you're lucky enough to get access to that. The message here is, this is who you are, and it will be a lifelong problem. But again, here's the irony. Dialectical behavior therapy, the gold standard for borderline personality disorder, is essentially trauma-informed care in disguise. It's mindfulness, distress tolerance, emotional regulation, interpersonal effectiveness. Everything about DBT screams, this is how you treat a nervous system that's been through hell. Which raises the question, why are we calling it a personality disorder at all if the treatment is literally trauma therapy with a different name tag? The split is more than semantics. It shapes lives. There are consequences for the split. The PTSD patient gets told this happened to you. The borderline patient gets told this is just who you are. One is given hope and honor, while the other is given shame. One gets a pathway to recovery, while the other gets a lifelong sentence. Same symptoms, same roots to completely different outcomes. For me, the question isn't just whether borderline is chronic trauma. The question is, why do we treat one group like survivors and the other like villains when the line between them barely exists? And what happens when we call someone borderline instead of calling them what they are, which is a trauma survivor? The consequences run deep. Borderline often reads as, you are the problem. whereas trauma reads as something happened to you. Over time, that framing becomes an identity. I'm going to give you some examples. I like to give real life examples because I think it allows you to think about how different scenarios actually play out. So, an example of this is a 22-year-old reads her portal after she has an appointment with her therapist, but she just went through a chaotic breakup. So she goes to therapy, talks to her therapist about the breakup. She's obviously not having her best day. She leaves the appointment, she opens the portal, and she sees that remark, that note. The client is displaying borderline traits. The 22-year-old closes the tab and immediately hears her mother's voice in her head. "Oh my, we know. You've always been so dramatic." The label doesn't explain her history of neglect. Maybe at the hands of that same mother's voice she's hearing. The label doesn't explain her history of neglect. It explains her. And it insinuates that she is defective. So she stops therapy for 6 months after that. Imagine this. A patient is told, "This is just your borderline acting up." So he leaves therapy and he doesn't return to treatment because now he believes there is nothing to treat, only a messed up personality that he's stuck to deal with. This matters because longitudinal studies and other works show BPD is highly remitting with care. 85 to 91% achieve remission over 10 years. And that's what they don't want you to know. Yet, shame convinces people they're lifelong lost causes. First, a way that we can do better, name the wound. We can name the wound. This is a way that if borderline personality disorder diagnosing makes you feel uncomfortable, this is something you can try. Name the wound. Just put it out there. Given your history, these patterns make sense. But then, immediately after, name the hope. Tell them. And these patterns change with skills and trauma work. And then most importantly, make sure you separate the person from the pattern. Tell them you're not your coping strategies. If you are upfront with people and honest and are genuinely looking out for their best interest and educating them in a way that isn't offensive or overly critical, most people are receptive to things you wouldn't think that they might be. So PTSD tends to route people to trauma therapy, right? BPD often routes them to crisis management or routine medication checks without ever naming the trauma engine. Imagine two patients present with self-harm and dissociation. The PTSD patient is offered EMDR and a safety plan. The BPD patient is offered a safety plan and a warning. Same nervous system injuries, different doors, different opportunities. Another scenario. A teenager completes all of their DBT modules in therapy flawlessly. Then they relapse after a family holiday. No one ever connected that the client's triggers were to the uncle who still comes to dinner. The unhealthy coping mechanisms are still there because the story stayed underground, it stayed hidden, and the root cause was not addressed. This matters because symptom and neurobiology overlap between BPD and trauma. The amygdala hyperactivity, hippocampal stress effects, prefrontal regulation load. These suggest different labels, same circuitry. So treatment should then converge on trauma-informed care. A way for you to better determine if you are dealing with what you think could be BPD, or if you think PTSD or chronic trauma, start with a trauma map when you're assessing. Timeline, triggers, the meanings, and then pair DBT skills with trauma processing, like EMDR, not instead of it. And then translate behaviors. Explain to them, fully immerse them in the conversation, empower them. Tell them this is a survival reflex. It's not your moral failure. Another huge issue is provider avoidance. What this is, when the label itself changes how doors or opportunities, like I said a minute ago, open or close for you. Healthcare providers brace, clinicians discharge sooner, and access in general narrows in ways that we don't even think about or have no reason to think about unless it's of special interest to you. Imagine this. Administration whispers, borderline, and 3 private therapists suddenly have no openings anymore. the same person labeled complex trauma to callbacks by tomorrow. Another example. Imagine handoff report. One provider says to another, heads up, she's borderline. The night nurse immediately stiffens before even meeting the patient. Rapport is lost before hello was even spoken. This matters because reviews and qualitative studies show BPD attracts stronger structural and interpersonal stigma than many other diagnoses, directly harming care access and quality. The ways that we can do better include banning the pejorative shorthand, replacing terms like manipulative with words like protest, safety signal. We can use split-aware team huddles to contain countertransference, align limits, and provide warmth. We can also track outcomes by the care being offered, not by the label that the client carries. Another issue is identity distortion, especially in adolescence. BPD is one of the few personality diagnoses stamped on teens at all. It's in the chart. It shadows every future encounter. At 15, after a suicide attempt, a girl gets diagnosed BPD. At 19, the college counselor reads the old note and defaults to crisis-only check-ins for the client. At age 25, she introduces herself as, I'm borderline, to her new provider. The label far outlives the context. Imagine the same teenager with a different framing. Someone might say to her, you've had a year of intense trauma-shaped patterns. Here's why your brain reacts this way. Here's how we help it heal. If said in a different way, that same teenager learns language beyond hopelessness. This matters because the DSM-5 allows diagnosing adolescents when features persist for greater than a year and cause impairment. So the label can be accurate, but must be handled with extraordinary care. Early trauma strongly predicts BPD features. Meta-analyses estimate markedly higher odds of childhood adversity in BPD versus controls. when and if we are diagnosing an adolescent, then pair the name borderline with a pathway and an expiration check. That could sound like, we'll reassess in 12 months. This is not your forever identity. Teaching identity skills, values, roles, safe belonging, alongside regulation skills. Lastly, put the trauma first in every letter, note, and handoff report that is given. Moving on, lifetime suicide attempt prevalence is high. Somewhere from 70 to 80% in some clinical cohorts. And mortality remains sobering, 5 to 10%. Dismissing verbalized suicidality as manipulative is unsafe and misses the communication underneath. Again, name the root, name the underlying issue. Say, these patterns are trauma coded. And then name the plasticity. Educate them. Reassure the person you're talking to that brains do change. And so do relationships. And then name the path forward, the path to healing. Tell them skills plus reclaiming your story plus safety equals recovery. And then lastly, name the person. Make sure you tell them and make sure they understand. If they understand nothing else by the end of that appointment, you are not your diagnosis. And nothing could be more true. Because maybe borderline isn't just a disorder, maybe it's trauma. And if that's true, then the treatment shouldn't be shame and suspicion. It should be the same kind of compassion and trauma-informed care we already know heals. For example, DBT, good old DBT, dialectical behavior therapy. This is the gold standard for BPD, like we've talked about. But look closely, it's essentially trauma therapy in disguise. It's just in a costume. Skills for distress tolerance, emotion regulation, and interpersonal effectiveness. And longitudinal studies show 88% of patients achieve remission within 10 years when given structured therapy like DBT. That's not hopeless at all. That's treatable. Then we have EMDR. eye movement desensitization and reprocessing. Traditionally used for PTSD, but increasingly used with BPD and CPTSD, which is complex PTSD, and the areas where they overlap. Meta-analyses show significant reductions in emotional dysregulation and in self-harm behaviors when EMDR is integrated appropriately. Another type of therapy is stigma therapy, which targets the deep wounds formed in childhood. The abandonment, mistrust, shame, and randomized trials show schema therapy produces significant improvement for people with BPD, often outperforming treatment as usual. Schema therapy also uses experiential kind of techniques like imagery rescripting, literally rewriting traumatic memories. There's also mentalization-based therapy, which is called MBT, and it helps patients understand their own and others' states of mind. It is particularly powerful for reducing self-harm and improving relationships. 18-month MBT programs show self-harm rates cut in half compared to standard care. Then there are somatic and body-based therapies. Talk therapy is powerful, but trauma isn't just stored in the mind, it lives in the body. Somatic experiencing works with nervous system freeze and fight or flight patterns, and it uses body awareness to release or discharge survival energy that got stuck. So it serves as an outlet for that stagnant energy. And then yoga and breath work. Randomized trials show yoga improves emotional regulation in trauma survivors. One study found trauma-sensitive yoga reduced PTSD symptoms by 31% compared to control groups. There's also polyvagal informed practices, which involve anchoring exercises such as safe sounds, grounding techniques, literally when they say go outside and touch some grass, cold water, humming, shift the vagus nerve out of fight, flight, and back into safety mode. This, particularly polyvagal informed practices, can be practiced daily outside of therapy rooms. And possibly one of the most effective techniques is meditation and deeper spiritual work, mindfulness and loving kindness meditation, which is really the core to DBT, but for whatever reason, often glossed over. Studies show loving kindness practice increases self-compassion and decreases shame, which is key. It's essential for BPD recovery. self-compassion training, the Kristen Neff model, involve exercises like soothing touch and self-compassion journaling to reduce self-criticism, which is a huge driver of BPD symptoms. And then there are contemplative practices. Some researchers are exploring how contemplative silence, extended meditation retreats, I've been looking into this, non-ordinary states like psychedelics, breath work like Kundalini can help people rebuild a self after trauma, create a new normal, a new happy, a new way of thriving. Psilocybin assisted therapy in the early stages of the trials shows a lot of promise for trauma, specifically trauma, depression, and potentially complex trauma presentations as well. Some simpler lifestyle and relational healing methods that can be used on a daily basis, or just things that we can be more intentional about. Consistency and safety, because people with BPD who report at least one consistent, supportive relationship are twice as likely to remit within 6 years compared to those without. This translates to human connection heals as much as therapy. Surrounding yourself with the best environment that you can. Sleep, nutrition, movement. Dysregulated circadian rhythms amplify emotional dysregulation. Stabilizing nutrition has measurable impact on mood swings. Unconditional spaces. Maybe healing really does begin with just being accepted, not when symptoms disappear, but while they're still there. A young adult, a teenager, told for the first time, you don't have to earn your right to exist. You're just safe here. You're good. You can be you. That moment often becomes the foundation for real change. And then just to add on a couple other therapies and methods before we finish this episode. We've talked about DBT, EMDR, schema, MBT, all the evidence-based therapies. But I also like to talk about the edges. What about the practices that don't get talked about in textbooks, but might actually help people who live with chronic trauma and borderline patterns? Sensory deprivation and float therapy. The idea behind this is zero input environments like float tanks calm the nervous system, lower cortisol, and induce deep relaxation. Some of the potential benefits, it can help to quiet emotional overstimulation and enhance mindfulness. The risk may include triggering dissociation or intrusive thoughts if this method is tried too early in healing. I think this will be best for those who already have grounding skills established and want to push mindfulness to a deeper level. Like we've talked about, and you'll hear me talk about again, psychedelic assisted therapy, psilocybin, MDMA, and ketamine. The idea is that in clinical settings, psychedelics disrupt rigid thought patterns and allow for emotional processing, which goes back to the neuroplasticity that we've discussed. Research is showing there's a 67% remission for severe PTSD after 3 sessions when using MDMA-assisted therapy. MDMA-assisted therapy is 67% remission. So early studies suggest psilocybin may help with trauma-related depression. This is relevant to BPD because it could help break cycles of shame and reactivity, but risk destabilization if not carefully supervised or carefully attempted or executed. These are not FDA approved for BPD, but cutting-edge research suggests trauma healing potential for sure. Like I mentioned, breathwork and altered states of consciousness, like Kundalini, holotropic, Wim Hof, coherent breathing. The idea behind these methods is using breath to bypass the thinking brain and then access stored trauma. The benefit is potentially unlocking suppressed memories, having an outlet for survival energy, and or creating emotional epiphany, or emotional breakthroughs. A risk of this could be without a skilled facilitation, it could flood the brain, flood them, or re-traumatize even. Breathwork in altered states are a very powerful non-drug way to access the nervous system, but these methods should be guided. The extended silence and meditation retreats that we talked about earlier, Vipassana or silent retreats allow the nervous system to reset by stripping away external chaos. The benefit is deepening mindfulness, self-awareness, and deepening tolerance for inner experience. A risk could be for those prone to dissociation. Silence could definitely amplify or intensify that. Careful timing, again, in your healing process matters. Advanced tools for people who've built a foundation of regulation skills already, who want to deepen their practice. There's also neurofeedback and brain stimulation, RTMS and TDCS. The idea behind neurofeedback is training the brain waves, EEG neurofeedback, or stimulating regions through RTMS to rewire regulation circuits. Research is promising for this treatment in the use of depression, PTSD, and emerging data for BPD. The benefits are reducing emotional reactivity by strengthening prefrontal control over the amygdala. Expensive, experimental, but it still has a growing evidence base. And then somatic and creative hybrids, such as dance movement therapy, which is moving trauma out of the body. There's art music therapy, which externalizes internal chaos in a way that words can't. There's also ecotherapy, wilderness immersion, which is just going into nature and nature exposure, which is shown to reduce rumination and self-harm urges. These aren't for everyone. They're not quick fixes, but they remind us that healing doesn't only live in manuals, textbooks, charts, and checklists. Sometimes it lives in the body, in altered states, in inaccessible areas, in silence, in suppression, in creativity, in the unexpected. Borderline has been framed as hopeless, but the reality is people are finding hope in places psychiatry never even thought to look. What if we stopped arguing about labels and started asking what helps? The science already tells us trauma-informed care works, somatic practices work, consistent relationships work, skills plus story plus safety works, and most of all, dropping the stigma works, because healing is not about erasing personality or history. It's about giving people back their right to live without shame. Here's the question we started with. Is borderline really a personality disorder? Or is it just chronic trauma dressed up in clinical language? When you look at the symptom overlap, the neuroscience, the treatment response, the line between them almost disappears. What doesn't disappear is the stigma. Labeling someone with borderline has been psychiatry's way of minimizing their pain. Instead of saying, you survived something traumatic, you survived trauma, we say, you are disordered. Instead of naming the wound, the roots, we name the person, we label the person. Once that label is stamped on it, especially when it's stamped early on in adolescence, it shapes identity, access to care, life opportunities, in the way every provider sees that patient from then on. That's not neutral, certainly not helpful. That's harm. But there's hope, because borderline isn't hopeless. Long-term studies show that most people with this diagnosis do get better. With skills, trauma-informed care, and unconditional spaces, people recover every day. The survival strategies that once looked like symptoms can be rewritten into resilience. Healing doesn't mean erasing your personality. It means reclaiming your story from the label psychiatry assigned you. It's definitely time to stop treating borderline like a life sentence and start treating it like what it really is: the imprint of trauma on a nervous system that adapted the only way it knew how. What would change if clinicians approached every borderline patient as a survivor from now on? What would change in the interactions if patients saw themselves not as defective, but as living proof of endurance. Because the reality is, borderline isn't proof you're broken. It is proof you survived through something. Because it is a trauma response. Next time, we're going to go even further. What does healing look like when we step completely outside the diagnostic box? When we stop asking, is this borderline or trauma? And start asking, what does this human being need to feel safe? Because that's where we're headed. Thank you for listening. See you next time.